Hello, everybody. My name is Surasawadee Ausavarat. I'm from Mahidol University, Thailand, and it is my pleasure today to talk about my research work entitled Efficacy of the TSH receptor mRNA in the follow-up of differentiated thyroid cancer, abbreviated DTC. I hope you find this topic interesting and informative. What I'm talking today are outlined here. First is the detailed information about the thyroglobulin as a tumor marker of DTC. Second is the review of the thyroid-specific mRNA as a surrogate or adjunctive marker. And third is my research on the efficacy of TSH receptor mRNA in the follow-up of DTC. And finally, my further study on the biomarker for DTC. Thyroglobulin is the glycoprotein dimer that help synthesis of the thyroid hormone. If the body needs the thyroid hormone, the thyroglobulin will be digested in the lysosome, and then the thyroid hormone are released to the bloodstream. The clinical significance of the thyroglobulin is that they are widely accepted as a tumor marker for differentiated thyroid cancer, particularly papillary thyroid carcinoma and follicular thyroid carcinoma. After thyroidectomy and radioactive iodine ablation, thyroglobulin levels can be serially monitored, and if there is an elevation of the levels, it indicates the residual thyroid tissue or recurrence or even metastatic disease. However, there are several limitations for the serum thyroglobulin. First, if the serum thyroglobulin can be interfered if the patient had endogenous anti-globulin antibodies, which can be found 15 to 25% of the patients, and it can be result in falsely low levels of the thyroglobulin. Second is the thyroglobulins had low sensitivity during thyroid hormone suppression therapy, so the clinician cannot differentiate by the thyroglobulin level whether the patients present with disease or in remission. And the final limitation is that the serum thyroglobulin had different methods of detection, so there are various sensitivity for each methods. For example, radioimmunoassay or the chemiluminescence immunoassay. So due to this limitation, many researchers try to develop new biomarker instead of detecting the thyroglobulin, which is the protein level. And the serum thyroglobulin detection is based on the antigen-antibody interaction, so there are some antibody interference. So they develop new biomarker by detection of the RNA level, which is depend on the molecular technique, and it is more sensitive. The first report on the thyroid-specific mRNA for the detection of circulating thyroid cancer cell in peripheral blood was first reported in 1966 by Ditkoff et al. They used reverse transcription PCR to detect the thyroglobulin mRNA, and they showed that these assays has no interference by the TGAB or the thyroglobulin antibodies, and the assays has high sensitivity during thyroid hormone therapy, and the presence of the transcript indicates or helps identify the patient at risk for metastatic thyroid cancer. Here is the example of the thyroid-specific mRNA, the thyroglobulin mRNA itself, or second is the TSH receptor mRNA, which responds to the TSH and helps stimulate the production of thyroid hormone. Third is the thyroid peroxidase, an enzyme that convert iodine in the bloodstream into iodine, and addition of the iodine to the tyrosine residue of the thyroglobulin. And finally, it's the sodium iodide symphoretic gene, which help the uptake of iodine into the follicular cell. These two genes, the thyroglobulin and the TSH receptor, is the most studied for the follow-up of DTC. However, this is the review of the thyroglobulin mRNA by Werberg et al. In 2004. He demonstrated that the TG mRNA has various sensitivity in the follow-up of DTC from highly significant to no such correlation of this assay, mainly because it has various methods of detection. For example, the detection is quantitative or not. If you use reverse transcription, it's maybe just a qualitative detection. And then later on, many studies use the qPCR or quantitative real-time PCR, which is much more sensitive, but maybe it's too sensitive, so there's no difference between patients and the controls. From the American Thyroid Association Guideline 2009 state that TG-mRNA may be a sensitive marker for persistent thyroid cancer. However, the extraction of RNA is still not well standardized, and its specificity still be questioned. So further studies optimizing the measurement are needed. So among the thyroid-specific mRNA, the TSH receptor mRNA seems to be the most effective for nowadays. The comprehensive study of the TSH receptor mRNAs are from Dr. Milas from Cleveland Clinic. Her study shows that the TSH receptor mRNA is very effective in the pre- and post-operative thyroid cancer management and also for long-term follow-up. So my objective of this study is to evaluate the efficacy of the TSH receptor mRNA in the follow-up of our thyroid patients. And second is to specifically look into the efficacy of the TSH receptor mRNA in the TGAB positive patients. And finally, to compare the diagnostic performance of the tumor marker, which is serum TG, and the novel biomarker, which is the TSH receptor mRNA, and the imaging study. We studied 160 DTC patients who follow up at our thyroid clinic, and 27 control subjects without the history of thyroid disease. Of these differentiated thyroid cancer, they are all had undergone thyroidectomy and at least one course of radioactive iodine ablation. The blood collection was done during the patient had thyroid hormone suppression therapy. We divided the patient into 4 groups. The first has 49 patients without evidence of disease. Second is the thyroid remnants based on their imaging studies. And third is the biochemical persistent disease, which are the groups of patients with positive tumor marker but negative imaging studies. And the fourth group is the structural persistent disease, which had both positive for the tumor marker and the imaging study, which can be divided into the local regional disease and distant metastasis. The demographic of the,
Attention please, attention.
And here's the demographic of the patients. The mean age are about around 50 years old, and the ratio of female to male is 4:1, and the median follow-up is 4 years. most of the patients, about 80%, are papillary thyroid carcinoma, and follicular thyroid carcinoma and other types of DTC are found in decreasing order. We also subgroup the patients by the TGAB status, and 17% of the patients are TGAB positive. And you can see that all patients can be detected by the assay. So we apply the cutoff value of the 2 picogram equivalent per microgram of total RNA. After applying the cutoff at 2 picogram, it seems that the group of distant metastasis had significantly higher level than the patient without the disease. This table shows the TSH receptor and mRNA levels divided by thyroglobulin antibody. And oh, it's all the time. And it seems that only the group of structural persistent disease and its subgroup of distant metastasis with the TGAB positive had a significantly higher level than the patient without disease. Almost done. It's almost done.
Attention, please. We have an alarm condition, third floor, center stairwell number 7. Evacuate the building immediately.
The diagnostic performance of the TSH receptor mRNA and serum thyroglobulin and the imaging study in identifying structural persistent disease. And you can see that for the TSH receptor mRNA, it has high sensitivity for the patient with the TGAB positive compared to the serum thyroglobulin. However, the accuracy of the TSH receptor mRNA is not better than the original serum thyroglobulin tumor marker. And from the overall results, the serum TG remains the most effective tumor marker in the follow-up of DTC. You can see that it gives the highest accuracy of 80%. So, conclusion. The TSH receptor mRNA seems to be highly sensitive in the TGAB positive patients only. And we found that 24 out of 27 of the TGAB positive patients were both positive for TGAB and the TSH receptor mRNA with the sensitivity of 88%, but the specificity is kind of low, it's just only 42.9%. And interesting that 2 of our patients with distant metastasis has unreliable tumor marker because the undetectable serum TG, and they had TGAB higher than upper limit. So these both tumor marker it's not beneficial for these 2 patients. However, the TSH receptor mRNA assay were positive. And this emphasized the serum TG remains the most efficient marker compared to the TSH receptor mRNA, which is much more expensive and time-consuming. And fortunately, the second generation of the TG assay made it possible to be sensitive enough for detecting basal TG. And so the TSH receptor mRNA may not be used as a primary test or the only test for the follow-up of the DTC, but it may be used as an adjunctive marker whose patients had serum TG not reliable due to the interference of the TGAB. My further study will emphasize on the cost effectiveness of the routine usage for the assays, specifically in the TGAB positive patients, and may extend to the novel markers such as circulating BRAF V600E in the diagnosis and the follow-up of DTC, which is not just a thyroid-specific but a tumor-specific marker. Thank you for your attention.